So cardiovascular compromise can be due to various factors in the newborn period, and you can classify it into factors due to vasodilatation. This is often seen with septic shock, systemic inflammatory disease which related to NEC and so on. And we have poor contractility related to maladaptation after birth. This is in the extreme premature babies where the sudden rise in the systemic vascular resistance after the cord is clamped, babies may struggle to cope with. Asphyxia leads to a similar problem as well, and septic shock in the later stages where the poor contractility adds on. If a baby has cardiomyopathy, it may affect with poor contractility. There are not many conditions in newborns with a high afterload, so we may have the maladaptation after birth. As I said, the systemic vascular resistance suddenly increases and the baby may find it difficult to cope. The more premature the baby, the more difficult it is. The importance of delayed cord clamping comes in here as well, that if we don't delay cord clamping, the preload is reduced as well, so the baby will struggle even more. Dilated cardiomyopathy can also cause high afterload. In shunt and arrhythmias, PDA obviously in a premature baby may increase the blood flow and make it more difficult for the pump to manage. AV malformations, I've seen many babies with vein of Galen malformation who present with the right atrial volume overload, dilatation and so on. And supraventricular tachycardia is not uncommon, and other arrhythmias like atrial flutter may sometimes present as well. Hypovolemia thankfully is not common, but you should be aware of, especially if there is antepartum hemorrhage or twin-to-twin transfusion where there may be a placental or twin-to-twin transfusion syndrome. You may have umbilical cord avulsion where it may be detected by the bleeding, but sometimes because there is a large blood loss at delivery, you may be finding it difficult to differentiate the maternal from the fetal blood loss. A small blood volume for the mother is actually almost the entire blood volume for the baby. Subgaleal hemorrhage is very important to identify because that can also lead to rapid blood volume loss, and insensible water loss can contribute to hypovolemia in the extreme premature babies if we don't take care of the humidity or we don't replace the losses appropriately. There may be polyuria due to various factors, and right ventricular dysfunction may be there. And diastolic dysfunction may happen with immature myocardium, tension pneumothorax, cardiac tamponade. So this is basically preventing the heart from filling adequately, and we may have hypertrophic cardiomyopathy. Most of the infant of diabetic mothers have hypertrophy of the cardiac muscle, but it doesn't lead to cardiomyopathy. But in the more severe ones, you may find that as a problem. Of course, we have to be alert about cardiac tamponade or tension pneumothorax in any sick baby, and tension pneumothorax especially in a ventilated baby. So there are many factors that contribute to early cardiovascular insufficiency. So we have the immature myocardium, we have the reduced contractility, altered filling, reduced cardiac output, and there is also reduced effect of the endogenous and exogenous catecholamines. The immature vasomotor tone, autoregulation is also affected. So we have decreased systemic vascular resistance, increased systemic vascular resistance which may contribute, and the catecholamine response is altered in the premature baby. That's one of the reasons why the hydrocortisone might help. And patent ductus arteriosus, which contributes by the nature of the shunt, and it's also dependent on the systemic vascular and pulmonary vascular resistance. As we know, PPHN, where there is increased pulmonary vascular resistance, the shunting becomes right to left. In sepsis, we have altered cardiac output. The systemic vascular resistance may reduce, as in the vasodilator picture that we get, and we may get impaired contractility as well. And capillary leak may cause reduced intravascular volume. Hypoxia may affect the systemic vascular and pulmonary vascular resistance, where the pulmonary vascular resistance can be increased with hypoxia as well, and impaired contractility may set in as an after effect of the hypoxia. In a baby who is cooled, it's very important to note that there is increased systemic vascular resistance. There is also bradycardia that may be associated, and the cardiac output may reduce, so we should be careful in these cases. In respiratory conditions like respiratory distress syndrome or PPHN, we have high pulmonary vascular resistance, right to left shunt, and hypoxia. In mechanical ventilation or pneumothorax, obviously if you are not careful, we may cause iatrogenic reduction of the cardiac output. So in high frequency ventilation especially, we should be very careful of this effect, and That's one of the reasons we used to monitor X-rays on a regular basis, but of course nowadays we go by the clinical parameters. You do an X-ray on the first few hours of high frequency, and then depending on how often you make changes. The periphery to central temperature difference may give you an idea as well, core to peripheral difference. In case of blood loss or early cord clamping, so remember that early cord clamping is not physiologic, and that is actually a source of blood loss to the baby. The blood that was supposed to come into the fetal lungs stays in the placenta, so you are depriving the blood of blood volume. So this reduced blood volume and oxygen transport capacity may result from the early cord clamping and reduced cardiac output as well. And as I mentioned earlier, in the extreme premature babies where the adaptation is already difficult because of the sudden increase in systemic vascular resistance, the myocardium is struggling to pump and cope against it. This early cord clamping prevents the preload increase which would happen with delayed cord clamping, and this compensatory mechanism is also missing in these babies.